Welcome to the e-textbook of echocardiography in congenital heart diseases. In this module, we are going to discuss about Truncus arteriosus. Truncus arteriosus is a single arterial vessel that arises from the base of the heart and gives origin to coronary arteries, pulmonary arteries, and the systemic vessels. It has got a strong genetic association with 22q11 mutation. The Collett and Edwards classification of Truncus arteriosus groups Truncus into 4 types. In type 1 Truncus, the main pulmonary artery arises from the posterior or lateral wall of the trunk and bifurcates into right and left pulmonary artery. In type 2 Truncus, the right and the left pulmonary artery arise separately from the trunk, but the orifices of the two vessels are close to each other. In type 3 Truncus, right and left pulmonary artery arise separately from the trunk and the origins of the two vessels are far apart. And in type 4 Truncus, it refers to origin of the blood vessels that supply the lungs from the descending thoracic aorta. In fact, type 4 Truncus arteriosus is VSD with pulmonary atresia and aortopulmonary collaterals. Van Praag's classification A1 will be equivalent of Collett and Edwards type 1. Van Praag's A2 will include Collett and Edwards 2 and 3. Van Praag's A3 will refer to origin of only one pulmonary artery from the trunk. The other pulmonary artery will arise from either the ductus or be supplied by a collateral. In Van Praag A4, the truncus is associated with aortic arch interruption, and so the main pulmonary artery, after giving off the right and left pulmonary artery, continues as the ductus into the descending thoracic aorta. So in type 1 Collett and Edwards classification, there is a short main pulmonary artery trunk. In type 2, there is no main pulmonary artery trunk, but the two branch pulmonary arteries will arise close to each other. In type 3, they arise at some distance from each other. Van Praag's A1 will be the same as type 1 of Collett and Edwards classification. A2 will encompass the type 2 and type 3 of Collett and Edwards. A3 will be patients with absence of truncal origin of one pulmonary artery with blood supply to that lung either coming off from the PDA or collateral. A4 is associated with underdevelopment of the aortic arch, often an interruption, sometimes a tubular hypoplasia or a discrete coarctation. VSD in Truncus arteriosus is generally large and results from either absence or pronounced deficiency of the infundibular septum and is cradled between the two limbs of the septal band. Rarely it can be remote and can be restrictive. Truncal valve is tricuspid in about 2/3 of the patient. In a few, it may be quadricuspid or bicuspid. Right aortic arch with mirror image arch branching occurs in about 1/3 of the patients. Interrupted aortic arch may be seen in 1/6 of the patients and is accompanied by ductal continuity of the descending thoracic aorta, and this is more frequently seen in 22q11 mutations. Subxiphoid short axis view shows a large subarterial ventricular septal defect in a Truncus arteriosus. We can notice that the common trunk that is coming off gives off the coronary artery and branches into ascending aorta and main pulmonary artery. This is the characteristic definition of Truncus arteriosus. The vessel that is arising from the base of heart should be single and it should give off the coronary artery, pulmonary artery and aorta. In the same subxiphoid short axis view, we can appreciate that the truncus is predominantly committed towards the left ventricle and there is less than 50% truncal override. The level of truncal override can be very variable. In this subxiphoid view, we can notice that the truncus is entirely arising from the right ventricle, which means it's more than 100% override there is a ventricular septal defect which is remote from the truncus arteriosus. And the anatomic size of the ventricular septal defect is smaller than the root of the truncus, which makes it restrictive. While most of the ventricular septal defects in truncus arteriosus will be located in subarterial location, very rarely truncus can have a remote non-committed ventricular septal defect. In the same subxiphoid view, when we make a further sweep towards the apex of the heart, we can notice the ventricular septal defect which is located in mid-muscular location, and the ventricular septal defect is far away from the truncal root. Whenever the ventricular septal defect is located in the subarterial location, it is cradled between the two upper limbs of the septal band. On this right ventricular en face view of the subarterial ventricular septal defect, we have cropped off the entire anterior free wall of the right ventricle and exposing the interventricular septum. We can notice the thick septal band, and the superior end of the septal band is in close relation to the ventricular septal defect. The large subarterial VSD is cradled between the two limbs of the septal band. Another RV en face view of the subarterial VSD, showing the relationship of the ventricular septal defect to the entire right ventricular surface of the IVS. In most of the patients, the ventricular septal defect will be in this subarterial location, and remote ventricular septal defects and restrictive ventricular septal defects are rare. In an apical four-chamber view, on an anterior sweep, we can appreciate the truncus arising from both the ventricles. The truncus again in this patient has got around 50% override. The apical four-chamber view shows the main pulmonary artery arising from the leftward wall of the trunk and immediately bifurcating into two blood vessels. One which courses towards the right is the right pulmonary artery. The other blood vessel which is seen entirely is the left pulmonary artery. Most of the truncus arteriosus will be associated with high pulmonary blood flows, which results in increased pulmonary venous return from the left atrium into the left ventricle. This causes dilatation of the left atrium and left ventricle and result in mitral annular dilatation. So truncus associated with high pulmonary blood flows will have associated functional mild mitral regurgitation. Most truncus arteriosus are associated with subarterial ventricular septal defect. However, in this example, we show an inlet muscular ventricular septal defect which is remote from the truncus, arising, and the truncus is arising entirely from the right ventricle. These remote inlet muscular ventricular septal defects are rare in truncus arteriosus. On a parasternal long axis view, we can appreciate the truncal valve in fibrous continuity with the mitral and tricuspid valves. We can notice the hypertrophy of the right ventricle and thickness of the free wall of the right ventricle. You can notice a large subarterial VSD with 50% truncal override. What is pointed out with an arrow is the origin of the main pulmonary artery from the posterior wall of the truncus. If we draw a line along the interventricular septum and draw it further towards the truncal valve, we will notice that 50% of the truncal valve annulus will be committed to the right ventricle and 50% of the truncal valve annulus will be committed to the left ventricle. This is defined as truncal override of around 50%. Sometimes truncus arteriosus can be associated with more and more degrees of override. This parasternal long axis view shows an example of a truncus arteriosus which is almost 80% committed towards the right ventricle. So this will be more than 50% truncal override. On color flow Doppler, we are able to appreciate that most of the truncal valve annulus is committed towards the right ventricle. An extreme example where the truncus is entirely committed to the right ventricle. This will amount to more than 100% truncal override. On color flow Doppler in parasternal long axis, we primarily concentrate on the truncal valve function and assess if there is any truncal valve regurgitation. Since Truncus arteriosus is associated with truncal root dilatation and different morphologies of the truncal valve, regurgitation is quite common. On a parasternal short axis view, we can appreciate the truncal root, trileaflet truncal valve, and when we sweep down, we can find the large subarterial ventricular septal defect. On a three-dimensional echocardiogram, we can appreciate the right and the left ventricle, a large subarterial ventricular septal defect, and the truncus taking off from both the ventricles. A couple of slides before, we had shown an example of a non-subarterial ventricular septal defect, a remote inlet muscular VSD, which was quite remote from the truncal root. On parasternal short axis view, we can appreciate the muscular ventricular septal defect in the same patient, which is quite remote from the truncus. On a parasternal short axis view, we can also appreciate the coronary artery arising from the truncus arteriosus, and in this example, we can appreciate that both the coronary arteries are having separate origin and there is a dual coronary origin from the truncus. We can also appreciate that the truncal valve is a trileaflet valve. In majority of the truncus arteriosus, the truncal valve is trileaflet. In about 1/5 of the patients, the truncal valve can be quadricuspid. This is an example of a quadricuspid truncal valve. When there is a quadricuspid truncal valve, all the four cusps may be either symmetric or sometimes one of the cusps can be very malformed and very small. Whenever a truncal valve is malformed, there will be some degree of truncal valve regurgitation. The same will happen when the truncal root is dilated also. So we need to assess the truncal root dimensions and the truncal valve annular dimensions in every patient with Truncus arteriosus. Quadricuspid truncal valve associated with a mild truncal regurgitation, the regurgitant jet is directed towards the left ventricle in this patient. On the parasternal short axis view, after assessing the valve morphology, when we sweep a little superiorly, we will be able to appreciate the main pulmonary artery arising from the posterior wall of the truncus, shown by an arrow, and immediately branching into the right and left pulmonary arteries. Main pulmonary artery can also arise from the leftward wall of the truncus. In this example, we can find that the main pulmonary artery is arising from the left lateral wall of the truncus. On a color flow Doppler interrogation, we can appreciate the main pulmonary artery arising from the left wall of the trunk and bifurcating into right and left pulmonary arteries. The main pulmonary artery, which arises from either the posterior or leftward wall of the trunk, will bifurcate into the right and left pulmonary artery usually. This is a normal pulmonary artery branching pattern. However, in some hearts, the main pulmonary artery will branch in a peculiar manner where it will form crossed pulmonary arteries or malposed pulmonary arteries. In this condition, we can appreciate that the right pulmonary artery will arise from the leftward wall of the main pulmonary artery, and the left pulmonary artery will arise from the rightward wall of the main pulmonary artery. When we show both the pulmonary arteries, we can notice that the left pulmonary artery is arising from the rightward side of the main pulmonary artery and coursing towards the left. The right pulmonary artery is arising from the leftward side of the MPA and coursing towards the right. Sometimes there can be different forms of crossed or malposed pulmonary arteries. In this example, the two pulmonary arteries arise from the leftward wall of the ascending aorta. There is an anterior branch that courses towards the left, and a posterior and inferior branch which courses towards the right. All these will represent different forms of crossed pulmonary arteries in Truncus arteriosus. The importance of identifying this crossed pulmonary artery origins in Truncus arteriosus is to avoid twisting of the pulmonary arteries during the conduit replacement. If the pulmonary arteries are twisted during the conduit anastomosis, that will result in a pulmonary artery bifurcation stenosis after the surgery, and they will end up in earlier conduit replacements. Sometimes pulmonary arteries can be hypoplastic and associated with stenosis in Truncus arteriosus. This is an example where the right pulmonary artery is diffusely hypoplastic and is very narrow in comparison to the left pulmonary artery. On a color flow Doppler interrogation, we can appreciate a mosaic turbulence in the right pulmonary artery caused by the RPA hypoplasia. However, the left pulmonary artery is unobstructed and has got laminar flows. When we do a Doppler interrogation of flows in the right pulmonary artery, we can notice a continuous systolo-diastolic gradients with the peak systolic gradients of around 70 millimeters of mercury. A majority of patients with Truncus arteriosus will have a normal left aortic arch. We can appreciate the normal arch falling on the left side and the arch vessel branches. Since Truncus arteriosus is associated with a large pulmonary blood flow, there will be a runoff of the aortic blood into the pulmonary arteries in diastole. This results in a diastolic flow reversal in the aortic arch, and the blood from the descending thoracic aorta will be drawn in towards the ascending aorta, and it will be flowing into the pulmonary artery when the pulmonary vascular resistance is low. Appreciation of this diastolic flow reversal is an indicator of low pulmonary vascular resistance in Truncus arteriosus. However, we should exclude a significant truncal valve regurgitation. The diastolic flow reversal in arch can also be due to truncal valve regurgitation if there is a severe truncal valve incompetence. Whenever the pulmonary vascular resistance is very low, we can appreciate a lot of diastolic flow reversal from the entire aorta. From the suprasternal view, when we visualize the aortic arch and its branches, we have to take a look at the thymus. The thymus is the echogenic mass that is seen immediately above the aortic arch. In patients who are having 22q11 mutation, often the thymic tissue will be very small or absent. In more than 1/3 of the patients with Truncus arteriosus, there can be a right aortic arch with a mirror image branching pattern. In most of the patients with Truncus arteriosus, there will be dual coronary artery origin, with the left coronary artery arising from the posterior and left facing sinus, and right coronary artery arising from the right sinus. On a 3-dimensional echocardiogram, the truncal root demonstrates both the coronary artery origins. We can see the left coronary artery origin as a gutter of the LCA, and again the right coronary artery as a gutter. Single origin of coronaries from either the right sinus or the left sinus is the commonest abnormality seen in Truncus arteriosus. In this example, we can find that there is a single coronary artery arising from the right sinus, and the left coronary artery arises from that vessel and courses posterior to the truncal root. In Colleton-Edward type 2 truncus, both the pulmonary arteries arise from either the leftward wall or posterior wall of the truncus. In this type 2 Truncus arteriosus, we can appreciate the right and the left pulmonary artery having a supra-inferior origin But the definition criteria for a type 2 truncus arteriosus is that the two pulmonary arteries should arise close to each other. In type 3 truncus arteriosus, the right and the left pulmonary artery origins are a little apart from each other. In this three-dimensional echocardiogram, we show you the RPA origin and the LPA origin, which are quite separate. This separate origin of the truncus arteriosus will need a longer button of the right and left pulmonary artery origins to be cut off from the truncus, and so the trunk will need to be repaired by using a pericardial patch. In this cropped three-dimensional echocardiogram, we can notice the right and the left pulmonary artery arising quite separately from each other. This will represent a type 3 truncus arteriosus. Collett and Edward type 2 and type 3 truncus arteriosus are included in Van Praag's classification under one common head as A2. Van Praag A3 type of truncus arteriosus will include truncus where only one of the branch pulmonary artery is arising from the trunk. The other pulmonary artery does not have any origin from the trunk. We show you one apical four-chamber view, a still frame where a pulmonary artery is arising about 1.4 centimeter above the truncal root. On a parasternal short axis view, we appreciate that this blood vessel that is arising from the leftward wall is coursing entirely towards the right lung. There is no left pulmonary artery seen. When the trunk gives off only one pulmonary artery and the other pulmonary artery is not having an origin from the trunk, then it is called Van Praag A3 type. In this example, we find that only the right pulmonary artery is coming off the trunk and the left pulmonary artery does not arise from the truncus. On a color flow Doppler, we can appreciate the flow of the blood from the trunk into the right pulmonary artery, and there is no left pulmonary artery at all. We need to carefully watch the color flows in the pulmonary artery in these patients. We can notice that in diastole, there is a flow reversal from the pulmonary artery back into the truncus. This is an indicator of extremely high pulmonary vascular resistance in the right lung. Truncus arteriosus, which are associated with only one pulmonary arteries, will have markedly elevated pulmonary vascular resistance in those lungs. In subcostal coronal view, we can appreciate the trunk with origin of the right pulmonary artery from the leftward wall of the trunk. We notice that there is no left pulmonary artery origin at all. On a color flow Doppler, we can notice the color flows from the trunk to the right pulmonary artery with absence of color flows towards the left side. A magnified view from the subcostal view, which shows the right pulmonary artery arising from the leftward wall of the trunk and absence of left pulmonary artery. In the last type, Van Praag A4, the truncus is associated with arch interruption. Here the trunk divides into ascending aorta and main pulmonary artery. The main pulmonary artery on the subxiphoid short axis view can be seen to continue as ductus into the descending thoracic aorta, and the ascending aorta will give off only the arch branches. On color Doppler interrogation from the subxiphoid short axis view, we can notice the flow of blood from the main pulmonary artery that is coming off the trunk towards the ductus into the descending thoracic aorta. In a parasternal short axis view, we can notice the main pulmonary artery from the trunk dividing into right and left pulmonary artery, and further to the left we can see a continuation of the main pulmonary artery as the ductus arteriosus. To summarize, truncus arteriosus is characterized by one great artery origin from the base of the heart that supplies the systemic and pulmonary circulation along with coronary arteries. Different classifications have been proposed under Colleton Edwards and Van Praag's. Subarterial ventricular septal defect is common. However, restrictive and remote ventricular septal defects can happen. There can be variations in the truncal valve morphology, variations in the pulmonary artery origins, and variations in the aortic arch branching pattern.